I would like to ask that in FET cycle, is there any significance of measuring the progesterone level where we are doing an embryo transfer in the freezing cycle?
Compared to the fresh cycle, I would say that there is not too much meaning to measure progesterone because, first the concentration of progesterone are not linked really to the action that progesterone does in the endometrium, particularly the two major actions. One is to prepare the endometrium after the priming of estrogens to be implanted by the blastocyst, and the other is to prepare the mother locally and generally with the immunotolerance for not rejecting the blastocyst and the embryo. The usual amount of progesterone that is given is in between 800, but you can go up, or you can mix with the subcutaneous. I don't have too much experience with the combination, but I know that you have experience, and I think that you have a very good result also with the combination. Yes,
very good results with the subcutaneous injections, and that increases the blood level very fast. That is within 1 hour only you get a very good blood level. So either you can have, for this Japanese study, that you can give 1200 milligram of the vaginal progesterone, or you can have subcutaneous injections can be added if you are giving 800 milligram to the patient.
Exactly. We usually, at least in my center, use more the 800 to 1 gram to support the luteal phase in this fat cycle. The other phase is slightly different.
And second thing is the serum levels are quite low. Whenever we give vaginal progesterone, the concentration in the uterus is very high. It is almost 10 times high. And that's why there is no point in measuring the serum level of progesterone when you are using vaginal progesterone as a primary line of treatment.
Yes, for sure, yes. Good. That is quite clear, yes. But
now, in FET cycle, in India, what we see that commonly the people are prescribing dihydrogesterone along with the natural micronized progesterone. Now, the pharmacology says that the dihydrogesterone does not work when endogenous progesterone is absent. So there is no corpus luteum, and that is why the dihydrogesterone is not acting on the endometrium very much. What is your...
First, I would say that this kind of combination practically doesn't exist in Europe, except very few centers, but I don't understand why they do. In any case, the use of dihydrogesterone is a little bit a contrast to the action of progesterone, because one of the things the natural progesterone is doing, and only the natural bioidentical progesterone, so the micronized progesterone, is performing, is to synchronize the endometrium. So this means that when I start giving, the endometrium follows steps in preparation which are the same as in a normal natural cycle with the production endogenous of progesterone. If you give any other progestins, this doesn't happen, as well with the dihydrogesterone. So to give one substance which put in phase the endometrium, and another which is not capable to put in phase, tell me what is the sense. It's not for sure synergistic. Eventually, you contrast a little bit the action of progesterone, is counteracting. Instead of helping, is doing the contrary. So I don't see any issue really. I don't know what is your opinion.
Yes,
but
that is also one recent paper which has been published in Human Reproduction 2022.
Oh yes.
That even a 10 milligram which is given 3 times a day. And I'm surprised that one of the co-investigator is Professor Grishinwald, who has already done the work on dihydrogesterone. He himself says that 10 milligram 3 times a day does not give the in-phase
endometrium. Because it should be underlined that in that paper they were able to measure the dihydrogesterone metabolite in the blood, which is very complicated issue. You cannot take the progesterone levels when you give a dihydrogesterone. And of course in normal patient you don't know how you measure dihydrogesterone because it's very complicated. Measuring dihydrogesterone, they observe that is not enough and not capable to prepare the cycle appropriately. So, of course, they wish to find a way to do this, but this is a sign that they are still very far away from a real scientific evidence that dihydrogesterone does something.
So it should not be combined ideally along when you are
I think there is no biological plausibility to do that.
People use different doses of progesterone, particularly when they are stimulating with the gonadotropin cycles, either in IVF or in an IUI cycle. Now, what should be the ideal dose of progesterone that should be given to the patient when you are stimulating the patient with gonadotropin, either for the fresh transfer or for the IUI cycles?
Now, the usual dose you start with is 600 milligrams a day, okay? Then now there is some trends, at least in some part of Europe, some of the very famous IVF center, to personalize this amount, measuring the concentration of the blood according to a cutoff which has been established by retrospective data, you know. So they say that, okay, if the cutoff is more than 10 nanograms, this means that your 600 milligrams is a good dosage. If it's less, go over, so add another 200 until you overcome this cutoff. This can be a useful way. This is valid for also intrauterine insemination, and remember, it's valid also on natural cycle in which we want to do luteal support in case of some difficulties, what we call unexplained infertility, but the patient is still not on, you know, on the way to have IVF cycle or workup. So we can use few months supporting the luteal phase in this way, and you will be surprised because some studies have already shown that 35–40% of patients may remain pregnant just supporting very well luteal phase.
This is very important information because lot of unexplained infertility patients are on the waiting list of the IVF, and they do conceive when you give progesterone support, and they can conceive spontaneously.
But you agree with me that the support should be not just 200 milligrams, you have to give it at least 600 a day.
600 to 800 milligrams.
Yes, because this is a real support for the luteal phase.
Many a times we give 1200 milligram, particularly when your dosage of gonadotropin is very high, because that also suppresses endogenous LH. You use agonist and antagonist. That has also decreased the LH level. You have given, suppose the HCG as an LH surge, that also decreases the endogenous LH. So in all these circumstances, many a times the requirement is high.
But I know that instead of some groups that use the blood concentration of progesterone, you rely also very much on your ultrasound capabilities. Tell us a little bit, because I mean you are an expert on that, about especially
level of progesterone by doing an ultrasound,
Doppler and so on. What are your target?
We always see the endometrium and see whether even the pre-ovulatory rise of progesterone is present or not. And second, before giving HCG or before giving a trigger also, we know exactly what is the progesterone level by ultrasound also. And the endometrium, we can see what is the progesterone effect on the endometrium.
So this can be a very good information. If you don't have a patient which are available for checking concentration, blood and so on, I think that the possibility to check by ultrasound in your office is another valid solution, okay?
Okay. So it should be used in a proper amount.